Put the camera on. Good afternoon again. I'm David White, the chair of the NNN. And now we come to your time for questions and answers. We've heard some great presentations, and I want to sort of thank you for those questions, and indeed thank the staff for the presentation, showing really the breadth and depth of the work here at the NNN. The first question I've got is for May, and then the second one will be for Roy, the Finance Director. So May, thank you for that presentation. The question is, how do we ensure that patients receiving palliative care have their wishes met about seeing family during their final illness? So if you kick off, May, then I might bring Nancy in as well.
Sure, I mean, that's been obviously quite challenging during this particularly difficult time during the pandemic. Certainly there is our usual visiting criteria, but it has been made a little bit more flexible for those who have a limited lifespan left. So the details obviously of that are that people are allowed to visit a little bit more often if unfortunately their loved one is sadly entering the end of life. That would have to be discussed at a ward base, but there is also a policy for that.
Nancy, do you want to add any comments to that?
Yes, of course. So we were very clear as an organisation that for patients who were at the end of life or had cognitive needs, communication needs, such as learning disability or dementia, or perhaps their condition had deteriorated while they were inpatient, that throughout COVID, we would make sure that we allowed one visitor, who was a named visitor, in full protective equipment, exactly the same as the staff, to be alongside their relative. And that proved to be a turning point for our county, because all of the organisations did the same thing. So actually, although we saw the stories on the national news where families and carers weren't allowed, we did not do that at the Norfolk and Norwich, and certainly through Wave 2 we will continue that process.
And may I add something else as well, personally from myself? My father has been unwell in a different hospital, and I can tell you how awful it has been not being able to visit him in person. You are literally stopped at the front door at this particular hospital. So I have to say, from a personal point of view, just how refreshing it is for us to be so flexible in this particular time.
Okay. Erica, is there anything that you'd want to add? So our medical director.
I'd just like to say how proud I am of this team. I think they've achieved fantastic things, really fantastic. As an organisation, we've grown their number, and we're now going to be sharing our experiences more widely, working with the other acute trusts in our STP footprint and with our community colleagues, so that we can offer the best possible care to patients at the end of life, which is absolutely essential.
Okay. Thank you. Switching tack now, there's a question in which I'll read. Donations are always welcome, of course, but to what degree are these used to cover areas that we might expect to be covered by government funding? Roy, do you want to give an initial response on that, and I'll then ask Sam to comment?
Yes, thank you, David. First of all, I'd like to say that whenever we receive a donation, we obviously make sure that we spend that donation in line with the wishes of the donor in the first place. That's an important part of what we do as a trustee. I can also confirm that when we spend charitable funds, it's always for the enhancement of services or staff welfare. It's never used for core NHS services that are exchequer funded or funded through government funds. We always make sure there's a clear delineation between the two.
Sam, do you want to add anything?
Just to add that we are very grateful for everyone who has made a donation, whether individually or through, there's been a lot of work, for example, through the Norwich Rotary Clubs over the last year. And some of the things that we've been able to fund with that money have included some enhanced research activity that we're undertaking for our frail patients, some additional work. We've had a big appeal called the Boudica appeal, which has been raising money for additional facilities for breast cancer patients. And also we've used some charitable funding this year to support additional investment in new state-of-the-art surgical robots. So that just gives you a sense of some of the other things alongside the COVID support that we've managed to use funding for this year.
Thanks, Sam, for giving us those examples. I'm going to move on, and I will be coming to Sam to kick off the answer, and then to this question, and then bring Chris Cobb, our Chief Operational Officer, in to comment as well. The question is, as finance is always an issue for the NHS, how will the hospital cope in the coming years with growing demand?
So as I talked a bit about, David, in my introductory remarks, one of the really positive things of our experience over the last few months has been our enhanced system working. And that is a testament to the strengthening relationships within our Sustainability and Transformation Partnership, our STP, and our work to become an integrated care system. So the approach to managing demand we're wanting to take is to work increasingly closely with community services and primary care to see how we can work together to manage demand and deliver care closer to home, as well as work with our colleagues in public health to look at how can we work with the general population to support healthier behaviours and lifestyles. But I'll hand over to Chris to talk a bit about how we manage demand within the hospital.
Thank you, Sam. One of the things I would say that COVID has shown us that some of the modern technology that is now available to us in the NHS just present us with some of the answers to this question. With ever increasing demand, both electively and non-electively, what we now need to do is use that technology to help us deliver smarter care, more efficient care, and allow patients to have better access to our services. I think we've gone past the point where we just continue to deliver care in that traditional model, which is actually quite expensive to deliver and is a drain on our resources and some of our expertise, which has had a lot of time and years invested in making it the top quality care that we can provide, is actually now spending a lot of time on traditional models, which could become quite transformational, modernized versions of that. If we can get that right, that will give us time back for our clinicians to give more patients more improved access to our services, and actually it will make us more efficient and reduce the costs. If we can get the stuff that we've learned from COVID right with our virtual consultations, now that's increasing the number of outpatient attendances that we're able to offer already, and to be fair, we're quite novice at it at the moment. We're still growing into that experience, and the more use we can make of that distance consultation and the virtual consultations, the better it will be. And actually that is, again, helping to reduce costs because it's quite an efficient way of doing it. We're not blind to the fact, though, that actually we've got an elderly population and our demand is going to continue to grow. And as Sam says, it isn't all about the NNN, it's about Norfolk, and how does Norfolk adapt to that? We have, with our partner organisations, started work on a single patient tracking list, which is one Norfolk-wide waiting list. It's in early stages of development, but that, again, that will help patients get access at the right time to the right services and reduce waits and reduce costs when you can potentially just access the right hospital at the right time rather than wait for either ourselves, the PASIT or the QEH. So I think there's lots of things coming that will help change the face of how care is delivered, which will reduce costs, enable us to get through more of that demand in a more efficient way.
And certainly, Chris, what the last few months has demonstrated is an accelerated approach to partnership in the system as a whole across Norfolk and Waveney. And I think we are pushing at an open door to work with colleagues in health and social care to be increasingly more patient sort of focused and actually try and reduce care where patients are rather than them always having to come into the hospital to receive services. The next question, I'd like Sam really to kick off, and then invite any other observations that people want to make. Do you think a regional fund raising event could be something that we could organise across all hospitals, similar to Comic Relief? Do you think that's feasible?
Ooh, well, we may want to bring John Paul in on this as leading our charity, but I think, as Roy talked about in his presentation, I think we've all been struck by how amazing the Captain Tom fundraising effort was over the earlier part of the year. And it has made us think about how can we better connect with our community, and are there opportunities to be more ambitious in how we organise our fundraising. So I think it's a good challenge, David. It's a real challenge I'd like us to embrace, because obviously we've got our 250th anniversary coming up of the Norfolk and Norwich in about 18 months' time. So there's lots of opportunities for us to think about how can we work with the community over that timescale.
Yeah, and that's something that we'll take away and talk with John Paul as head of charities, who's not with us at the present time. One, I think for Akesh, and then and no doubt that Erica and Nancy will also like your views as well. Really good question. What has the critical care team learned about treating patients through the pandemic?
Well, we've learned not to give up. We've learned to hang in there, because we know these patients have a slightly longer course. They tend to be ventilated for longer, and so so we're much more in tune with that. We've learned how to communicate with relatives better, along the lines of what Chris has said in terms of using IT. We've really upped the ante in terms of how we communicate with relatives virtually on those sorts of platforms, and I think that's been a huge bonus. We've embraced new technology. We've learned about new drugs. Research, the commitment to research has been reinvigorated, and I think the psychological element to patients and staff is also cannot be underestimated. I think the 2 days a week of psychology input on the unit already is producing huge dividends in terms of how staff who perhaps previously wouldn't have been keen to talk about their feelings, but now they are much more open to talking about stressful situations. Even myself, I'm not averse to speaking to a psychologist one-to-one now. So a lot has changed, but we can do better. I think we can improve our mortality even more, and hopefully, given the opportunity, we'll try and prove ourselves.
Yeah, well, thank you for that response. A very incredibly emotional time for everyone concerned, really, and I hope that you and colleagues have had a good break and managed to get a break, because clearly we're not out of the woods. So thank you for what you do. I'm going to move now. Oh, sorry, Erica and Nancy, please, would you like to offer any comments on that? Okay, no, okay. I'm going to ask Sarah Higson. I've got a question coming in. Sarah, can you kick off, and Nancy may well want to sort of come in as well. The question is, great to see a growing patient panel to keep the voices of patients and carers at the centre of care being delivered. How are the voices of those with disabilities, different ethnicities and religion, as these are important factors in care, represented on the panel?
Absolutely, and I hope I'm unmuted, because I have a tendency to mute myself too often. Thank you. I think, as I said in the presentation, these are key voices that we want to ensure are listened to and engaged with and involved. And whilst at the moment, I think the panel is small in number, we are hoping that, particularly through today, through raising awareness of the panel, that we are reaching out and encouraging the widest possible involvement from our communities in that panel. There are 10 more spaces to fill, and we are keen to hear from everybody in the community. We do have some representation from patients and community and carers with disabilities, with languages that are not English as their first language. So we have some representation and diversity on there, but we can have more, and we should and must have more. So please do get in touch with us if that is a particular area of interest for you.
Right. Before I bring Nancy in, Sarah, can you continue to sort of respond? Because we have another relevant question, which I'll ask, and then Nancy can pick up both as well. The NHS finds it particularly challenging to engage with our younger population, teens and young adults. What is the Trust doing to engage with this group of people so that we can harness their creativity in a sustained way?
So this is a piece of work that's really exciting because we recognise this, and we have wanted to focus on children and young people as part of our strategy, and we've got a fantastic team already in our children and young people's department who are raring to go. So already we've looked at how to gather feedback from our younger members and patients through something called Tops and Pants, which is a really fun way for children in particular to give feedback. So they would write something positive on a top and something rubbish on the pants. So that's a really good way to get feedback. And then the teams have been working with that rigorously to make some improvements. And we are being very proactive in taking forward our plans for a young children and young people's forum. So we're looking at possibly two. The one might cater for and target a younger age group, and then looking at the teenagers. And we have on our doorstep, of course, UEA and some really good colleges and student bodies out in Norwich and in Norfolk who I know would want to work with us and help us to develop our forums and opportunities to get involved. And of course, through our volunteering programmes, we'd be keen to hear from younger people to help us with that as well.
Thank you, Sarah. Nancy, is there anything that you'd like to add?
Yes, I would. I'm going to just talk about children and young people. For quite a period of time now, there has always been an adult, so a member of the patient panel on the senior appointments for nursing and midwifery and allied health professionals, and certainly for the deputy chief nurse post more recently. But we've now extended that, and the children's services team have their happy band of children and young people who are now going to be on the interview panels for any of the senior posts, and that's whether it's a doctor, nurse or a therapist. And that's absolutely right, because if you can't communicate with your client group, then it isn't going to work. So we're really excited about that. As you all know, children will tell you exactly who they want and who they don't want. So an exciting move forward. I think the other piece around respecting and inclusion and diversity is something I'm extremely passionate about and have been for many years, as is Sarah and the rest of the patient experience team. So we have Nick, and Nick leads on diversity, particularly around inclusion for patients, carers and families. And so that expands out not just for the patient panel, but all of our expert patients, and also patient feedback, making sure that we hear from seldom heard groups who may fit into that group. So we're making sure under equality and diversity and inclusion that we do incorporate all the views, and that includes our dementia strategic group. And I think we are now the first group in the country to have a policy for supporting LGBT plus and transgender for patients with dementia. And this is quite an incredible piece of work, and we will expand that out to other groups. So this is not just about staff, this is about our local community.
Thank you. And Nancy, that response sort of segues neatly into another question on inclusion, which I'm going to ask Paul Jones, our Chief People Officer, to initially respond to. Then Sam, I'm sure, will want to come in. The question is, what can be done to ensure that the Trust Board is reflective of the ethnic diversity of the staff and patient group? Paul.
So that's a really good question. It's something which the Trust Board is very conscious of. Our senior leadership team does reflect one particular Caucasian background. So there's a number of steps we've actually taken. The first is to try and actually improve the diversity of the board immediately, and there is support in place to have a developmental scheme for non-executive directors from a ethnic minority background, which we will have in place before Christmas. There is also a scheme we're actually looking at to progress talented BAME colleagues in our workforce to actually into more senior leadership roles, and we're looking at a 5-year plan to actually develop that. We've also looked at some of the barriers to our recruitment process. So over summer, we did a very comprehensive piece of work looking at over 35,000 candidates who'd applied for us over the last 12 months in the organisation. And we identified at key stages where people actually aren't progressing on from either shortlisting or appointment. That's been shared with each of our divisions. So again, they can do their own analysis on that. So for each professional group, each level in the organisation and each clinical division, we've actually now got a skeletal framework about where the problems are, and we're actually starting to actually address those. We're also piloting balanced interview panels. So for a number of years, we've tried to actually balance interview panels in respect of gender, and we're now looking at balancing that in terms of ethnicity as well.
Thanks, Paul. Sam, do you want to add anything?
Just to say that we recognise that diversity in all senses of protected characteristics is a really important agenda for the trust going forward. It's really important that our leadership team reflects both the population but also the staff that we work with and we serve, and so it's going to be a big priority for us in the years ahead.
Okay, thank you, Sam. Changing tact and moving back to the COVID, and Chris Cobb, I'd like you to sort of kick off responding to this question, please. So the question is, with a national increase in hospitalisation due to coronavirus, what is the current situation at the NNUH? How many patients are currently being treated in the wards and in ICU? And how does this compare to the start of the pandemic?
Thank you, David. Yeah, I can answer that one. So in terms of patients currently in the hospital who are COVID positive, there are two. They're both on Crinkleford ward, which is side rooms, entirely in side rooms. So we're quite comfortable with our position at the moment. We were very well prepared the first time round, and I think this time we're equally well prepared. We're just going through now an exercise in making sure that the lessons learned from the period of end of February through to 1st of July are fully embedded in our policies and our processes. So we will be issuing for ourselves a revised policy, hopefully next Tuesday, which will make it really clear to everybody how we're going to deal with anything that comes our way. We've got nobody in critical care who's COVID positive at the moment. We are aware, though, that colleagues at the Queen Elizabeth and in Cambridge and elsewhere in the region have already started to see an upturn in COVID-19 hospitalisations, and it's likely that it will come to us in the next couple of weeks. As a working model, we were hoping to have all of our plans in place and ratified going into the October half term in a couple of weeks' time, because that always for the NHS is traditionally a tricky period when the children have a break and parents come into contact with their children for a week. The week immediately following that is always a period of lots of coughs and sniffles and colds and natural things. That's going to be sat alongside real presentations of COVID this time round. So our planning is fully encompassing of what we would do to separate out flu, COVID, norovirus, and patients presenting with traditional illness which contains none of those infections. So we're in a good position at the moment, but we're acutely aware of the fact that colleagues elsewhere regionally and certainly in the northeast, northwest are having a harder time, and that level of COVID activity is most likely to come to us at some point between now and end of February. But what I would say to reassure everybody is I think we're in a really good state of preparation. We've just got to tweak our lessons learned from the first time round and we'll be ready to go.
Well, certainly that was the board's view when we reflected upon the last 6 months experience earlier today, Chris. Erica, would you like to sort of comment on the question?
Sorry, just unmuting myself. I think as an organisation we're well prepared. I think staff feel much less anxious than they did prior to our first wave earlier in the year. We of course have more beds because we've opened the new ward block, first and second floors, which will make a significant difference. And we have our negative pressure block with additional respiratory rooms, which will really help. We're working very closely with the region and of course the national teams to make sure that we support our neighbours should we need to, as we are a regional surge centre for the East of England, and we will continue to do that as part of the work that we do.
Okay, thanks for that. And I just don't know, we're just sticking on this, just as another question come in before I come to a question for Simon. So again, really, I think perhaps if Erica and Sam, if you want to pick this up, or Chris as well, it's just, but basically, how are we tackling waiting lists alongside managing issues like COVID? Perhaps if as you were talking, Eric, if you just want to pick that up, then perhaps ask Sam to come in.
So we are doing far much more work than we were at the height of the first wave of the pandemic in terms of our elective work and waiting list work. We are focusing on the sickest patients first, and of course our cancer care continued throughout our pandemic response, as it should. We're working very hard to make sure that those people who've been waiting the longest are contacted by our clinical teams, that they have the opportunity to have a conversation and to escalate any concerns they may have. And those people who become sicker while they are waiting, we're escalating their care. We are working very hard to manage the demand on our services, but it is clear that over the pandemic response, we couldn't do as much as we would normally have done over those months in previous years. We're now trying to regain a balance with that and to deal with the number of patients waiting. And we're really sorry for those patients who've waited much longer than any of us would have wanted them to.
Thank you, Erica. Sam, do you want to add anything?
Just to add that, as Chris mentioned earlier, the other thing we are exploring is a single patient waiting list across Norfolk with our acute colleagues as a way of trying to ensure that patients get care as quickly as possible. And as Erica was saying, we are absolutely focusing on those patients with cancer or those who are long waiting or who are urgent. But I am very, very appreciative of the fact that we have got patients waiting a long time now. And as Erica says, I think we can only apologise for that.
Thank you. And just from the sort of board's perspective, this is something that the board and the subcommittees review on a monthly basis and are kept up to date with progress we're making. Because as Eric has rightly said, I mean, we know that people are waiting far too long, and we're doing everything that we can to try and treat more patients. I've got a question now of changing tact, and Simon, can I ask you to pick up this, please? The question is, the parking at the hospital is universally a cause for despair. When will this be addressed? Its availability, its cost, and the difficulty of paying at departure from the car parks that are privately operated.
Thank you, David, and good afternoon, everybody. Yes, it is an ongoing challenge. We do recognise it. I think it's probably fair to say that many of our management meetings, parking is discussed as a challenge both for staff and visitors. There's a couple of things I would say. We have, as a hospital, invested in the park and ride service, which operates from Thickthorn, and we do try and encourage wherever possible patients to use that service. It runs every 15 minutes and costs just £1. That's not suitable for everybody. We understand that. So in 2021, hopefully when we get through the end of the pandemic, we are aiming to bring on an additional 100 visitor spaces close to the car park. In relation to the private car park, so visitors to the hospital will have noticed that there's a multi-storey car park being built adjacent to the hospital. That is a private car park operated by a third party. We are aware that some patients have had some issues accessing the temporary car park that's in place at the moment. We have a good dialogue with the private operator of the car park, and we'll continue to raise concerns that we get from patients and visitors about the use of that private car park with the operator. We have a good working relationship, and we meet with them frequently, so we will continue to do so.
Okay. Thank you, Simon. Another question, and Sam, would you like to respond to this, is what collaboration is there with other hospitals and healthcare professionals outside our immediate area, and what joint ventures are in place or planned?
So I think it slightly depends on how you define our immediate area, but as I said in my introductory comments, one of the things we're really proud of this year is the fact that we've managed to set up the Norfolk and Waveney ENT service and the Norfolk and Waveney urology service, working in partnership with the James Paget and the Queen Elizabeth. We now are working together on a number of joint services. So, for example, Nancy and her colleagues work very closely with the Queen Elizabeth on a shared infection and prevention control team. And we intend, where possible with our partners, to continue to strengthen that collaboration. If the question is aimed about outside of Norfolk, we do have a number of specialist and tertiary services that we run here at the Trust, which often have a regional footprint or sub-regional footprint. So there are ongoing conversations with other hospitals in the east of England about how we could work more closely together with those.
Okay, thank you, Sam. I'm going to move on to further questions, and this is one I think, Paul, could you respond to this? Could I ask what the ratio of women to men on the board? By my reckoning, it's about 50 to 50%, sort of 50%, 50%, but you'll correct me.
Yeah, so we have 16 members who actually attend our board meetings, so we're just shy of 50%.
Yeah, but in terms of voting members, it's probably works slightly the other way, but around 50-50 anyhow. Okay, thank you. Question for Chris, please. How is the hospital working to clear the backlog of OPD services, which was stopped during the peak of COVID?
Thank you, David. Yeah, it goes back essentially to the statement I made earlier about the use of the technology and the distance consultations. We were quite fortunate in some regard during the first phase that we were able to maintain urgent and emergency outpatient attendances in this building and at the local Spire Hospital, and to some degree up at Cromer. What we're going to try and do now in this second phase is run all of our services as normally as possible and maintain a COVID response. And in order to do that, that means that we're going to have to do more distance consultations and use that technology to our advantage. So we've had a look at what we could do differently at Cromer, and we will be doing more outpatients up at Cromer. We should also be using our Grove Road City Centre ophthalmology service this time round, and we had to close that the first time round. And we're going to optimise this building as best we can. We have to be very mindful that we are still in an environment where we have to adhere to the National Infection Prevention and Control Guidelines, which is encouraging us to maintain 2 metre distancing for the safety of our staff and our patients at all times. And of course, that does provide us with some hindrances when we're trying to get same volumes through as we were pushing through pre-COVID. But we're looking at ways that we can adapt our services and work through that, and maybe extend some of our working days in some areas, and make use of possibly weekend mornings in some services, because that's the easy way forward. But we are determined that we're going to make inroads into those backlogs. What we can't promise is that we will get back on track by the end of this financial year, but we're going to do everything we possibly can to make as big a dent in that backlog as is possible.
Okay, thanks very much, Chris. And can I just, for the record, just sort of say to viewers, really, you've seen 1 or 2 nice backdrops. Can I assure you that Chris is not in a European sort of country, but is actually in the hospital, and I think May also had a good backdrop in terms of more exotic backdrop. But we are live. People are in the hospital. Oh, this is nice. I've got another. It isn't a question; it's a comment, but I'd like to read it if I may, because it certainly I think says a lot. It's anonymous, and it's I've worked for the NNUH for almost 10 years. Now I want to say a personal thank you to Sam, Nancy and Erica. Since you guys took over, the hospital is a great place to be again, and is unrecognisable today compared with 5 years ago. well done. We don't say that often enough to you guys. That's great. Thank you very much. I'm sure the individuals appreciate it, and as a board, it's good to get that feedback. Talking of feedback and engagement, we've now got a question on how are we overcoming the barriers to engagement when we can't meet in person. Very topical. Roy, as a finance guy, do you want to kick off with this? Because this is good, and then I'm going to ask Paul as the Chief People Officer to come in.
Sorry, David, I've got some interference. Would you mind repeating the question?
No, the question really was a bit of a curveball to Roy, really, in terms of overcoming the barriers of engagement when we can't meet in person, but something that we as a board have been discussing, indeed, earlier today.
The irony of technology not working on that question, David. I think it's been a really interesting time across the NHS, and what we've seen is fantastic fast adaptation by NHS workers to move into virtual environments, and we've seen across our hospital a rapid increase in our digital technology. We've seen people come together like today on this virtual forum and start to work in different ways. But for me, I think the thing that I find most impressive is how clinicians have moved to virtual clinics so quickly and started to look at outpatients in a completely different way. There was a target that was going to take us 5 years across the NHS to achieve, but as an NHS we've managed to achieve that in many regards in 5 weeks as we went into the COVID disaster. It does bring with it the challenges. It can be a very impersonal way of communicating, but I think our staff have done a great job of overcoming that with the patients and with their colleagues to get the most out of this new way of working.
Yeah, I entirely agree. Engagement is difficult when you can't meet, but I think the team have done a superb job during this period about setting up this kind of facility, for example. So we're all learning as we go along about novel ways of engaging, and which becomes kind of commonplace now. But I'd like to, engagement is a big issue for the board in terms of patient engagement and staff engagement. So Paul, would you want to pick up the staff engagement? And I'll ask Sarah Higgson if she'd like to comment about patient engagement, because as Nancy said, we're absolutely thrilled to launch our patient engagement and experience strategy. Paul.
Thanks, David. And it is a really good question as well. It's a completely different experience having come through the pandemic, and we obviously need to keep our patients and our staff safe. But I think with the technology, it's also provided us with better opportunities for engaging with people and engaging more widely as well. So we've had improved communication as we've been going through the pandemic. So colleagues have regularly held connected sessions or open discussions. I think there's also opportunities for extending that into engaging with patients and families as well. But we've also provided, recognising that it's a new experience for people, remote webinars about how you actually manage virtual teams, which may be located in the hospital and beyond, and also guidance on keeping in touch with staff. So there are those opportunities, and I think also we need to supplement that with some opportunities for people actually coming into the workplace, but in a secure environment, so through touchdown facilities or socially distanced meetings. And our own board earlier today was actually meeting in a socially distanced way, but after we'd done a risk assessment on it, just to make sure that everybody was safe on it. But I think the technology does enable improved engagement as well.
Thank you. Sarah, do you want to offer any observations? And I'm going to ask Nancy if she wants to come in on that as well.
I think one thing that surprised me throughout COVID was how readily our community actually embraced the digital opportunity. So whether that was through virtual clinics, phone clinics, and also the opportunity to engage with us as an engagement and experience team through social media, and also through the patient panel itself meeting rather like this. And actually it has enabled some people who might find it difficult to get involved because they're working, they can't make meetings easily, they perhaps don't travel so well. They've actually been able to get more involved than in the more traditional kind of engagement methodology. Having said that, we are extremely aware that not everybody has access to digital tools to become engaged. So we really need to think that through. And whilst during the pandemic, we've been very focused on trying to be still engaged somehow, we now need to be thinking about, as mentioned, how could we get COVID secure spaces for people to come together and have conversation face to face in if we need to.
Yeah, okay. Thank you. Final word, Nancy, on this?
Just to say that actually what COVID has taught many of the specialities is actually across Norfolk, our patients do really like the virtual connection, and I will identify particularly rheumatology as one specialist group. The specialist practitioners here have reached out and they're on a weekly basis talking to patients, and patients have felt really connected, so we know that it works. And we've also looked at how we can have patient support groups and expert patients in a Zoom meeting. So actually this is really going to be how we connect and engage with patients for the future.
Okay, thank you. And we're coming up to time. We've got a final question, a specific question, which I'm going to ask Erica if she'd like to respond to. And the question is, are there any plans to bring in expertise on pancreatic disorders, as although Gastro covers some, expertise is often at the UCL in London?
So we do manage some pancreatic disorders within the NNN. It is a number of years ago now, and I think Chris will probably remember that some of our surgical services for pancreatic diseases were decommissioned from Norwich and were moved more centrally within the region. And that was because of our population. So some of these diseases are very rare, and we didn't have a big enough population to maintain those services locally. So we don't have plans to change that because the population hasn't got big enough for us to change that, but we do have pancreatic expertise on site.
Okay, thank you. And that actually brings to an end this Q&A session, and indeed brings to an end this, our first virtual, hopefully our last virtual AGM, because we're hoping to be able to welcome you in to the organisation, to the Trust next year for a live event. But I hope that you found it interesting, and really appreciate you tuning in. Any comments about the event, so how we can make improvements going forward, would be welcome as well. So thank you for your interest and your support to the Norfolk and Norwich, and we look forward to continuing the conversation in other ways. Thank you.